And what we found is that if there was an abnormal endorectal coil MRI, 13 of 16 patients were diagnosed with prostate cancer. Okay? 3 cancers were missed and called normal MRIs. However, if there was a normal MRI, 32 patients were normal, and even if there was an abnormal MRI, most of the patients did not have cancer. So first of all, with an abnormal MRI, you definitely need to go back and sample, because not everything you're seeing on MRI is cancer. The majority of them were not cancer. But also, you have a very, very high negative predictive value of 91% if you have a normal MRI with elevated PSA negative biopsy for clinically relevant cancers. Now, what do I mean clinically relevant cancers? The 3 patients who were diagnosed with cancer, even though they had a normal MRI, all 3 of them had minimal Gleason 6 cancers. And these are cancers that will not necessarily be treated, they may just be followed. So for clinically relevant cancers, a normal MRI, even with elevated PSA, is a very, very strong predictor of nothing clinically important going on. Let's talk a little bit about active surveillance, which is an increasingly, more commonly becoming indication for prostate MRI. And when we started using MRI for follow-up of active surveillance, we started actually looking at patients with low-risk prostate cancer, which we weren't doing before. Okay, sorry. And in many cases, it tells us what we can see. Okay, so the patient is clinically suspected to have very low-risk disease, but sometimes we found that they were wrong. Like in this case, clinically minimal disease, Gleason 6 in 2 of 10 cores on the right, less than 5% of the biopsy specimen, PSA 8.5. The patient was planned for active surveillance. The physician sent him to make sure he wasn't missing something in the anterior gland, the superior gland, or the central gland, which is the areas we're looking for on MRI. And he did. There was something there. We see a large tumor in the anterior central gland. Clearly, this is not a patient for active surveillance, and he underwent prostatectomy. However, more interestingly, is that since we are now looking at these very low-risk prostate cancers, minimal Gleason 6 prostate cancers with MRI, in addition to learning what we can see, we've begun to learn what we cannot see. And we're learning about our limitations with MRI. So what we cannot see is just as important as what we can see. Here's a 60-year-old patient who is a BRCA carrier, and I hope that everyone here knows that BRCA gene mutations are high risk for breast cancer in women, but also high risk for prostate cancer in men. And he had a slowly elevating PSA for over 6 years with 2 negative transrectal ultrasound-guided biopsies. The last one was a year ago, and then 1 year ago on his trust biopsy, they found minimal disease in the right mid-gland and put him on active surveillance. Okay? His PSA is now 21. Now, can we see PSA 21 with no cancer? In a large prostate, yes. The highest that I've seen with a normal MRI was 52. Okay, so anything is possible. Now, we can all clearly, easily see this is the same as the case I showed you before. There's a large central gland anterior tumor with extracapsular extension here, both on diffusion weight on ADC map and dynamic contrast enhancement. However, what's interesting in this case is that on the right side, where he had a biopsy-proven low-grade cancer, we don't see anything. And we know there's a cancer there and we don't see it. Okay, here's another case. This is a patient with a PSA 5.3 with minimal Gleason 6 on the right side. Okay, nothing on the left side on biopsy. So prior to active surveillance, they did an MRI, and there's a clear tumor on the left side, even with some maybe capsular involvement. But again, nothing on the right side where we know there's a cancer. So we know that we don't see all prostate cancer on endorectal MRI. Okay? Now, one more thing to note in this patient here is that not all tumors enhance. This is a post-contrast image. The tumor does not enhance at all. So when we're doing multiparametric imaging, we need to put all the pieces together, but not rely on only one of them. So we know that we don't see all cancers. How many cancers do we not see? Well, if the volume is over 1 centimeter, then we have a pretty big chance of seeing the cancers. We see about 80% of the cancers, even if they're Gleason 6 cancers. However, if it's a small Gleason 6, under 1 centimeter, then there's about a 50% chance that we won't see the tumor. Okay? And this is important. important to know because the meaning of non-visualization of a tumor on MRI prior to active surveillance does not mean that there is no prostate cancer. And patients always say, but you don't see the cancer, maybe I don't have cancer. No, you do have cancer. But a negative MRI confirms that the clinical suspicion of minimal disease is correct, and it supports the clinical decision of active surveillance as opposed to patients who have a clear tumor that we see with capsular involvement or a large tumor and so on and so forth. So here's a patient with a Gleason 6 tumor on the right and a PSA of 5.7. Okay, what do we see?